attendance. You can get CME credit for this. And we're going to launch right into our speakers this week. So I think everyone knows Dr. Schupper. He is one of our now PGY 5 residents who's coming off of research. He got his undergraduate degree in neuroscience and psychology at Hopkins, followed by an MD at UCSD before coming to Mount Sinai to start his residency here. He's been very academically productive and started off with an interest in cranial neuro-oncology and defected to spine, much to my chagrin, but the spine world will be better for it. Alex will be presenting on an interesting topic to me, and I think to many of us, which is on how we study complications in surgery, and how they affect our practice. So, Alex, I'll turn it over to you.
Thanks, Dr. Morgenstern. Let me. All right, can everyone see my screen?
Yeah, looks good.
All right, thanks so much for the opportunity to speak this morning. This morning I'll be speaking about complications, and not in terms of how we typically think of complications, but the actual science behind complications and why it's important to study them. So to start off, I have no disclosures. I like to start with a quote of someone who we all know very well, Mr. Michael Jordan, who said, "I've missed more than 9,000 shots in my career. I've lost almost 300 games, and 26 times I've been trusted to take the game-winning shot and missed. He's failed over and over again in his life, and that is why he succeeds." I think as neurosurgeons, as people who constantly strive to perfection, we can learn a lot from MJ, who is infamous for his constant scrutiny over his own game, analyzing every shot he missed, and really always aiming to perfection. I feel like there are a lot of parallels we can draw as neurosurgeons. And as an example that may resonate more toward us is one of our recent graduates, Frank Uke, who, despite how good we are, there's always room for improvement, and it shows that we all do make mistakes. But on a serious note, so let's take a step back and identify what complications are. So they're defined as an event in which care resulted in an undesirable clinical outcome, specifically an outcome not caused by the underlying disease state, which can result in adverse outcomes such as a prolonged length of stay, permanent patient harm, or requiring even life-saving intervention, or possibly contributing to death. And so to really understand the study of complications, we have to rewind the clock over a century ago to a general surgeon named Ernest Amory Codman, who you probably all recognize the last name, Codman, a subsidiary of the Johnson & Johnson Group, who was a general surgeon at MGH in the early 1900s. And what made Dr. Codman unique was that he presented his outcomes on a set of cards to categorize his own errors that were known very famously now as end result cards, where he actually followed his surgical patients for 1 year after surgery. Now, this was completely revolutionary at the time. No surgeon in the modern day had previously done this. And this was not only met with opposition, but the hospital actually refused his plan when he publicized it, and they revoked his surgical privileges, and he was no longer allowed in the theater after it was announced that he wanted to track outcomes for his patients, to give you an idea of the theme of surgery back then. Now, this was really revolutionary work, as he actually led the initial standards committee, which was an integral part of the inception of the American College of Surgeons back in 1913. So without Dr. Codman, the American College of Surgeons wouldn't have taken off as it did early in the 20th century. This work was later further developed by anesthesiologists. And as we know, anesthesia has really spearheaded the idea of outcomes measures and complications. And they started the Anesthesia Mortality Committee back in 1935. And since then have really been at the forefront of framing our current system for managing complications, tracking outcomes, and ensuring high quality of care. So why study complications? Now, we talked about the early inception of complications, but it's actually been a mandate for 40 years now by the ACGME. So back in 1983, the ACGME made it a required aspect of every training program in this country to hold regular morbidity and mortality conferences as part of their education for residents and trainees. And after that, in 2000, the IOM very famously published Error is Human, which I'm sure many of you are familiar with, where they cited that almost 100,000 people in this country die annually due to medical errors. making it the top 3 cause of death in this country. And the famous quote is that the problem is not bad people in healthcare, but rather is good people working in bad systems that need to be made safer. So some quotes I think will better frame why it's important to study complications are the following. So the WHO published that it's a major burden in global health issue, not just in this country, but abroad. It's been called the hidden pandemic. It's been associated with a significant financial burden. There's a scarcity of literature on complications. It's not something widely studied throughout all subspecialties in medicine. And there really is a lack of consistent reporting at the base of it. Now, a book that, in my opinion, I believe all people in surgery, especially younger trainees, should be familiar with is Atul Gawande's Complications. And there are 2 quotes I really take away from this book. The first is the following: no matter what measures are taken, doctors will sometimes falter, and it isn't reasonable to ask that we achieve perfection. What is reasonable is to ask that we never cease to aim for it. And then the second being that not only do all human beings err, but they err frequently in predictable pattern ways. I think this is really important in terms of the foundation of this talk, because the logical reasoning from this quote is if we err in frequent and predictable pattern ways, how should we study complications? And so this takes us to Domingo et al.'s paper, which if you guys follow Nature, you'll know that recently came out in the past 3 months, entitled Consensus Recommendations on How to Assess the Quality of Surgical Interventions. In this paper, they used the Zurich Danish Consensus Conference, which was an independent jury-based consensus conference model of a jury that was composed of independent members where they identified key stakeholders from different aspects and perspectives of clinical care, everyone from ethical and legal backgrounds to psychological backgrounds to patient advocates, patients themselves, as well as providers. And they separated these groups into 9 multidisciplinary experts. There were 3 phases as far as the study. The first phase was the preparation phase, where they identified panels, selected important experts and juries to understand what are the important drivers of assessing quality of surgical interventions. Phase 2 was actually meeting within these conferences and panels and discussing the evidence, coming up with recommendations. And then phase 3 was creating the final recommendations from their deliberations. As you can see here, this was a multi-year effort throughout the 3 phases. And so there were 9 panels, which I think is something really interesting about this study is where these panels came from. So panels 1 through 5 were the perspectives of the individual stakeholders. They were perspectives from the patient, the providers, the payers, societal perspectives, and then the legal ethical perspectives, which are panels 1 through 5. Then the remaining 3 were different aspects of outcome measurement, analysis, and finally interpretation. Each panel was asked to answer several specific questions on their topic. And what's important, something unique that this study did is they used the individual classification system to attempt to standardize these quality measures and where complications occurred. And they used the Clavian-Dindo classification where complications were graded between 1 through 5, 1 being any deviation from the standard postoperative course, and 5 being a patient's demise. And what's important, as we'll talk about in the final recommendations later on, is that they also use CCI, which is a standardized way to normalize the Clavian-Dindo grade, where it creates a normalized value for each degree of complication. So as far as the jury's recommendations, I apologize, they came up with 8 recommendations, which they used in their final deliberations, which I'll talk about in a second. So there were 9 total recommendations that the juries concluded on. The first was the timing of assessment. The second was the standardization of measurement, again, talking about the Clavian-Dindo classification and how we can normalize it with CCI. Using patient-centered metrics, such as patient-reported outcomes measures or PREMs to improve patient care. Fourth was the benchmark, creating an industry standard, if you will, as far as complications and how expected each complication is in surgical practice. 5 was identifying high-risk patients, patients who are more likely to experience certain complications compared to others. 6 is appropriate data management of how we take in this data and how we utilize it appropriately. 7 was being active in mitigating circumstances that may lead to mistreatment. 8 is understanding the cultural and demographic factors unique to each individual outcome. And then finally, the 9th recommendation was to create a culture of accountability and support. So from these, the jury concluded on 7 final statements, which I think are really important, especially when assessing outcomes in a department. The first being to record parameters at standardized time points, whether it's a week, a month, a year following a complication, routinely using PROMs and PREMs in clinical care, recording both individual and global morbidity using a standardized metric such as the Clavien-Dindo classification or the CCI, identifying industry standards or benchmarks, and comparing results to others who are your peers in the same field, routinely using interdisciplinary mortality and morbidity conferences, interdisciplinary being the key there, creating data quality guarantors at every institution, and then finally following the TRACK principle, which some of you may be familiar with, which stands for transparency, respect, accountability, continuity, and kindness. So one of their major conclusions was that it's warranted to create a new culture in dealing with unwarranted outcomes. And what they found, and has been published by the IOM recently, is that most surgical wrongdoings are actually the result from multiple systemic factors and not one individual source. And the jury recommended creating a shift in cultural blame from the individual to the collaborative and collective learning. Now, this all seems like maybe broad and vague principles, but how do we apply this to our individual practice here in neurosurgery? So I think what's interesting is 20 years ago, JAM actually came out with this article on how we should discuss errors in morbidity and mortality conferences. And one of the things they looked at is, does specialty matter? Should we make M&M or QA conferences standardized across all specialties? In this comparative study, they compared 100 internal medicine cases versus 232 surgical cases. And what they found was really interesting. It was that IM cases were often 3 times longer compared to surgical cases in terms of presentation. And what's interesting is that between medical and surgical cases, there's actually a pretty stark difference in terms of what we like to talk about and what we feel are necessary to report. So in internal medicine cases, we're much less likely to discuss adverse events. And when compared to surgical cases, only 18% of IM cases focused on the actual errors causing the adverse events versus 42% in surgery. So as a result, this group concluded that conferences should be specialty focused to best address unique circumstances within a department or a field. And so in terms of where these conferences should come from and who should be included in these conferences, a paper from over a year ago by Kaufman et al. In the Journal of Surgical Education found that adverse events are commonly multidisciplinary. Actually, the vast majority of cases do involve multiple disciplines with regard to a single patient. And what they found is that all cases discussed addressed at least 4 of the 6 ACGME general competencies. And just to remind everyone, there are patient care, medical knowledge, PBL, or practice-based learning, systems-based learning, professionalism, and interpersonal skills communication. So in terms of how we assess the role of complication conferences within our field in neurosurgery, so in case anyone here needs to be convinced that QA conferences are important within our field, there was an interesting review written by Nancy Epstein in 2012, who found that there were several major improvements over the past decade in terms of improving neurosurgical practice just through mortality and morbidity conferences. One was a paper by Drake et al., which showed that helped define shunt-related mortality in pediatric neurosurgery. And specifically with shunts, it helped identify indications of shunt failure and the need for shunt revisions. So there are many protocols beyond just the field of pediatric neurosurgery that have really improved the standard of care. And this has all been done through M&M conferences. There was recently a study published by Kashiwazaki et al. In Toyama, Japan, in World Neurosurgery, who in Japan, they have not had mandated M&M conferences for as long as we have here in the US. And so in this study, they tracked clinical outcomes of different types of trainees over a 5-year period and identified the early study period as 2 years after institution of M&M conferences, and then a late study period for the 3 years subsequently. So what they found is in a single neurosurgery department, the majority of mortality events were from cerebrovascular, followed by tumor, followed by trauma. And then what they found is that morbidity events actually improved with morbidity and mortality conferences. But then they went a little further, which I think is even more interesting. What they found is that when they looked at the different types of events, they didn't see a big difference in terms of instituting MMCs with unavoidable events. But as you can see here, there was a significant difference in terms of learning and adapting practices within their culture of improving avoidable events. And something from a resident standpoint that I also thought was really interesting is that while there was a significant effect for both attendings and residents seem to have an even larger effect size, an almost 2x effect size in terms of preventing avoidable events compared to attendings. So in case the residents are questioning the importance of MMM conferences, we are the most impressionable, not to anyone's surprise. So going back to our paper here in Nature this year, how do we standardize complications in neurosurgery? So from this paper, they use this jury-based consensus, but on a practical level, what does this mean as far as neurosurgery? And if time allows, I would love to hear input from the audience. And so these are some of the perspectives that I came up with. I'm curious to hear everyone else's views of how we would organize a jury-based consensus within the field of neurosurgery. So do we make this from representatives from different regions around the world? Do we use chairmen or chairwomen from different departments? Leaders in different academic subspecialties? Do we divide it by vascular, tumor, spine, etc.? Or should we leave it up to representatives throughout career spectra? Should we include residents, junior faculty, senior faculty? Or should we just include the ABNS and standardize it in a similar sense of how we do the oral boards, for example? And it brings into the question of who's the stakeholder in the quality of the delivery of care in neurosurgery. Similar to how the consensus recommendation worded, do we include patients in this conversation, providers, payers, lay people from society, or legal and ethical experts? I think these are all really important questions that we have to address. And then taking an analytical approach into the final statements offered by the jury, we can really critique our department and how we identify the QA process within Mount Sinai Neurosurgery. And so reflecting on how we do, I think from these 7 perspectives, there are 5 that we do really well here at Mount Sinai in terms of just being critical of our QA process. I think we do a really good job in terms of 1, 2, 5, 6, and 7, where we're really good at tracking data. We're very transparent. We have very regimented outcomes in terms of when we present complications as they arise and quality metrics. I think one thing that this paper talks about, which is something that I feel like especially in neurosurgery is not well elucidated, is standardizing complications such as using the Clavien-Dindo classification or normalizing it with CCI, which I think would be an interesting thing to look at. And then finally, benchmarking. How do we benchmark an appropriate level of care within neurosurgery? To me, there are 3 aspects that we have to keep in mind in terms of creating an industry standard for quality in neurosurgery. One is technical. Are the technical errors that we experience the same as those that happen in other departments, other institutions? Are these one-off technical errors, or do we see the same errors coming up time and time again? The local ecosystem. This is something that I feel like we do a really good job here at Sinai discussing. Being on top of infection rates, whether we're missing trays or instruments that delay cases and create longer operating room time or longer anesthesia time, provider availability and communication. We're in a very complex system here at Mount Sinai, and that creates an additional level of scrutiny. We have to deal with patient transfers regularly. We are tasked with transferring patients from other centers that may not have the ability to have full neurosurgery care. And we have many modes of communication, something I know Dr. Kellner and Dr. Zimmering have extensively talked about, the use of WhatsApp and different ways to effectively communicate between teams. And are there better ways we can optimize that within our department? So before I wrap up, I just want to acknowledge that we do have a very high commitment here at Mount Sinai Neurosurgery to the QA process, from the department leadership to our extensive QA committee that you can see here, it really is an important aspect of our training and our education. And I'm very grateful, especially as a resident, to have the ability to engage in such an extensive QA process to provide patients with the best care and to form my surgical training. Thank you so much for your time. I'm happy to take any questions.
Alex, I think they raise a good point, and you raised one about benchmarking and sort of establishing what are achievable and reasonable goals for different rates of complications. What would be your suggestion for how we would get together and do that as a specialty? Because I think that's where we're headed. I could see it in our system meetings on the topic where each department presents benchmarks that they're trying to reach. And we don't have that many of them because we're a small specialty and we don't have sort of evidence-based benchmarks. So what do you think?
It's a great question. I think especially in neurosurgery, where it's such a small field, right? There are only 4,000 neurosurgeons in this country who are regularly reporting quality outcomes. I think we really have to do it from the top down, from AANS, CNS, and make it something protocolized and standardized, where we come to these conferences, whether it's from the EC, et cetera, and really establish these metrics that shunts, for example, have to have between a 1 and 3 infection rate or whatever it might be, some industry standard that's based on peer-reviewed evidence. Kind of similar to how the Brain Trauma Foundation comes up with these guidelines, that they have certain levels of evidence that are rigorously discussed over many years with multiple committees to make sure that it truly is an industry standard. I feel like we don't do a great job with that in neurosurgery, and it ultimately comes down to transparency. We have to have it from the EC level down in terms of leadership worldwide in neurosurgery and how we can standardize that. And I think ultimately, like I said, it just comes down to departments being transparent, publishing complication results and rates, and understanding what the threshold is going to be for that industry and who falls above it and below it, and what actionable things we can do to mitigate that.
Yeah, I agree. And I would add that I think multi-institutional registries are very important in this. I think if we don't demonstrate our own evidence, then other people will. So whether it's payers or Congress or other groups that are non-neurosurgeons are going to start to impose their will upon us if we don't do it as a specialty. And a number of subspecialties have already sort of started doing this. And I think it's becoming increasingly widespread that multi-institutional collaborations are producing these large swaths of data that can help sort of support the benchmarking of different complications and what the success rates of different surgeries are expected to be. Do we have other questions? I'm sure somebody else has a comment or a question. Quiet crowd today. Okay, well, we'll take a minute. I just want to give Dr. Boylan, we're a little bit ahead of schedule, so I want to give Dr. Boylan a minute to get her slides ready. I'm going to a brief informal welcome to Dan and Ainsley. I know you guys just got started. I'm not going to put you on the spot today, but welcome to the department. And we'll take a few minutes out next week to more formally extend our welcome. Oh, wait, I see a question in the Q&A, Alex. Oh, here, Dr. Chowdhury.
Hi, good morning. Can you guys hear me?
Yes.
Yes.
Excellent. So since we have time, and this is an extremely important topic, Peter, can you give me a couple of minutes to just add a comment while we're waiting for Dr. Boylan?
Yeah, please.
Okay, let me put my camera on. Okay. Good morning, everyone. First of all, Alex, that was a fantastic presentation, and we're very happy to have you in the spine world. I didn't realize this was a defection, but the truth is, what you're talking about is so important. And I think we have to make sure as this field that we not just define the parameters. And I know you understand all the complexity, because it's not just picking an infection rate for shunt or a spine fusion or whatever, because there's different types of cases, right? I remember distinctly having a conversation with Dr. Gokaslan and Dr. Shuba when they were at Hopkins maybe 15 years ago. And Dr. Gokaslan was defining the field of sort of big pelvic tumor surgeries, and where the infection rate expected was 10, 15, 20% in his population, and it used to be 30 or more. And so he had a 4% infection rate, and he was getting heat from his institution because he was higher than the others. Why are you higher than the others? So it's not just important to stratify what the expected outcome is. We have to stratify the cases and the pathology so we're making fair judgments. And I know that you and Dr. Morgenstern and I and others are trying, and Susie and others are going to work on that with spine. So I do think that really defining the expected thing is not just an overall thing. It's really for each population. The hospital tries to do that with length of stay, but even that is imperfect. And so I think that I encourage everyone to help work on that. We, being a leading institution, which so many multi-specialty leaders really can take a lead in trying to help with this. And maybe it will require computers, AI, and other things to really help to look at a case and see